I would like to introduce a case of small cell lung carcinoma metastasis to a pancreas well-differentiated neuroendocrine tumor and its related pitfalls. Prehistory of a case is 68-year-old man who was hospitalized to the Hospital of Lithuania and University of Health Sciences with a pancreas tail tumor, due to which surgical excision of distal part of pancreas was performed and a tumor up to 2,6 centimeters diameter was found. In a histopathological examination, a tumor morphology consists of two quite different components, one of which was quite well differentiated part with trabecular structures and cells with small nuclei and quite large amount of cytoplasm. And contrary, different component was formed by highly atypical polymorphic cells that had large nuclei and less amount of cytoplasm. Also, high mitotic activity was seen, and differently in a well-differentiated part, no mitotic activity was seen. In fact, regardless of a clinical diagnosis, the tumor was suspected to be heterogeneous neuroendocrine. By protocol, neuroendocrine neoplasms should be evaluated by a specific algorithm steps that you can see in this arrow, and that begins with confirmation of neuroendocrine differentiation by using specific neuroendocrine immunomarkers. As you can see, both tumor components are positive in pancreas tumor, and it confirms neuroendocrine differentiation. Second step is confirmation of epithelial origin, which is also confirmed by specific epithelial immunomarker, which is positive in both tumor components. Assessment of tumor proliferation is checked by key proliferation index, and the key reveal different activity in these two tumor components. In well-differentiated part, it was just up to 1%, and in poorly differentiated part, it was very high, about 85% in hot spots. So our diagnosis was pancreas well-differentiated neuroendocrine tumor with a component of poorly differentiated neuroendocrine carcinoma. Such combination was quite strange and uncommonly seen. But to our surprise, a few months later, transbronchial biopsy was performed related to abnormal findings on chest computer tomography, and in histomorphology examination, we saw highly typical cells infiltration that were similar to those of poorly differentiated component in pancreas tumor. Furthermore, these cells were also positive for neuroendocrine tumor markers and positive for epithelial marker pancytokeratin. Moreover, confirmation of pulmonary origin was established by using specific immunomarker TTF1. So our thought was maybe it was a small cell lung carcinoma metastasis to well-differentiated pancreas neuroendocrine tumor G1, and this theory was checked by using TTF1 immunomarker in primary tumor in pancreas. And as you can see, in a well-differentiated component, it is absolutely negative, and differently in poorly differentiated component, which is shown here with asterisks, it is completely positive. So our final diagnosis was pancreas well-differentiated neuroendocrine tumor G1 with small cell lung carcinoma metastasis, and due to World Health Organization neuroendocrine neoplasms classification, which was revised in 2017 and 2019, G3 category was reclassified into well-differentiated neuroendocrine tumor G3 and poorly differentiated neuroendocrine carcinoma. By clinical investigations, it was determined that well-differentiated neuroendocrine tumor can progress to poorly differentiated neuroendocrine carcinoma. That's why both of these components shouldn't be seen in a one tumor. Thank you very much for your attention.